Let's assume you make the diagnosis. There it is, sitting on the scan. Boom, PE, done. What do you do? All right, so in order to answer that question, we need to break it down into the different types. There's an asymptomatic PE, symptomatic PE, submassive, massive, and the big line break, chronic thromboembolic pulmonary hypertension, which is not acute since it's got chronic in the word. We're going to break these down based on whether or not there are symptoms, whether there's a sign of heart strain, whether there's hypotension or not, which will determine what treatment they get and also determine disposition. Where are they admitted to? You'll see this works out really well. So an asymptomatic PE is one that you got because you looked for something else. And, oh, wow, hey, there it is. They don't have any symptoms. There's no sign of heart strain because they don't have any symptoms, and they're certainly not hypotensive. The treatment for this patient is heparin, bridge to warfarin, or NOAC, go home. But regardless, they're going home. You can just give them a NOAC and send them out. If you want to do warfarin, they need a subcutaneous bridge. They need to do it for 5 days or until the INR is 2, whichever is longer. If a person does have symptoms, but they have no evidence of heart strain, they're not hypotensive, these also get a heparin to warfarin bridge. We're using the same logic of the DVT. Heparin-derived, platelet-derived mediators, also turning off the unstable clot, reducing a chance of extension, and they get admitted to the floor. They get admitted to the floor because they need to be monitored. Chances are nothing's going to go wrong, but the next day they get their insurance ready, they get subcutaneous heparin for their warfarin bridge, or they do the NOAC. But the initial stabilization of the clot is done with subcutaneous heparin, and they get admitted. Asymptomatic goes home. Symptomatic gets admitted. Submassive and massive, I'll argue, should go to the ICU. Now, students and learners alike get submassive really messed up. They hear the word massive and think big. And they get tricked into seeing, wow, there's a saddle embolus. Look how long it is. It's huge on the screen when they look at the CT scan. It has nothing to do with that. It has only to do with the presence or absence of heart strain. A submassive PE has heart strain but is not hypotensive. These patients, I'll argue, should get a heparin infusion. This is my method and my approach and my practice pattern, and I'll explain the evidence in just a second. These patients should go to the ICU because you don't know if the person with heart strain is going to get worse and convert into a massive, or if they're going to get better and convert into a symptomatic. You determine whether there's heart strain or not using the brain natriuretic peptide, troponin, and echocardiogram. If the BNP is elevated, it is a sign of atrial stretch, right ventricular failure. If the troponin is elevated, myocardial injury, right heart failure. Bowed septum, right heart failure. You're looking for signs of right heart strain, and if you find any, it's submassive. Now you can see the chart just filling in itself, right? So if it's symptomatic, there's going to be right heart strain because they're hypotensive, because of right ventricular failure, they have a massive PE. Massive PEs get TPA, and they also go to the ICU. A recent study was released that said you should maybe give submassive PEs TPA at presentation, as long as they're not old and don't have a bleeding risk. My interpretation of that is if you have a BNP of 201 and a troponin of 0.7, it's positive, so you got put into the submassive category. If your BNP was greater than 15,000 and your troponin was 27, you got put in the submassive category. And so what I think should happen is the heparin infusion is started, stabilize the clot, based on how explosive the heart is. If their blood pressure was 91/61, they were included in submassive. If their blood pressure was 89/59, they're included in massive. So the closer you are to massive as a submassive, the more likely you should be to give the TPA first. The closer to symptomatic you are, that is, the less explosive the labs and imaging, the less likely you should be to put the person at risk for TPA. But if you're in the ICU, you turn the heparin infusion off, you give them TPA if they get worse. That's why they're in the unit. So if they're hypotensive, it's easy. If there's no heart strain, it's easy. If there is heart strain, you have to decide how close to death are they.